So, to continue our theme of research, really pleased to welcome Tarani Chandola from University of Hong Kong and University of Manchester, who's done some work around. Well, I'll let Tarani explain it. Are you there, Tarani?
Yes, I'm here. Can you hear me okay?
Yeah, loud and clear. Let me start your presentation and fire away.
Thank you so much for this invitation to come and speak about this research that myself and my colleague Patrick Rixell did. We were based at the University of Manchester until just last year, but we moved to Hong Kong, so we're now based at the University of Hong Kong. Yep, so this research has just come out. It's just been published in the LANCET Regional Health Europe. It's freely available, so you can go online and have a look at it if you're interested. And that's why Paul got in touch and asked me if I'd like to present. So I'm very honored to talk to you about this piece of research. So the reasons why we did this research was because when I looked at the evidence base for housing interventions in relation to disability outcomes, I was really surprised by a lack of evidence, especially when I looked at the reviews on healthy aging interventions, for example. There was almost no mention of housing interventions or systematic reviews on disability risk factors and interventions to reduce disability. And again, housing barely gets a look in. There is a wealth of studies on housing accommodations and modifications in relation to falls preventions. And a lot of the studies use sort of randomized control trials, experimental designs to look at multifactorial interventions. So home adaptations is one of many interventions, including occupational therapists and exercise programs. So that although these are sort of successful interventions that do reduce falls, it makes it really hard to sort of specifically determine the specific effect of home adaptations, like putting in a railing. So that was one of the reasons why Patrick and I were really interested in doing this piece of research. The other reason that we were interested in is because we were interested in looking at outcomes beyond falls, so particularly at social outcomes and more subjective well-being outcomes like quality of life. Mobility impairment is the most prevalent form of disability facing older adults today. As we've been hearing, home modifications or home just accommodations are structural changes in the indoor or immediate outdoor environment to help people to be more independent and safer in their own home and reduce their risk of injury. We were particularly interested in the role of external housing modifications because we thought that, external housing modifications may enable people with impairments and disabilities to go outside, to be more independent and have a social life. So there was this really interesting study that a lot of you may already know about, which is the evaluation of the care and repair service in Wales. And this is the kind of observational study that we wanted to do, but one of the reasons why this study was very interesting is because on the left-hand side, it gives some results that were counterintuitive. So this is on the x-axis, you got time in years, so the amount of time people were able to stay in their own home. And on the left-hand side, we see actually the darker blue lines, actually the very dark blue lines are people with mild levels of frailty or people who don't have any frailty. And they actually had lower probabilities of remaining in their own home compared to if they were a care and repair client compared to non-clients. So this seemed to be saying something quite opposite to what we expected, which is that having home accommodations should prevent people from moving to an institution. But actually, it seems to be suggesting, at least for those with mild levels of frailty, the home adaptations arising from care and repair services were enabling them to move into an institution. Now, of course, this is because it's an observational study design, so we're not able to randomly allocate people into care and repair services. So, so actually, the authors of this study showed that that actually the people with even mild or some levels of frailty, they may have had underlying conditions, health conditions that they were not able to control for. And actually, when they looked at the more severe end of frailty that's shown on the right-hand side, the results are exactly as expected. So people in the darker blue lines are more likely to remain in their own home after 5 years compared to people with the same level of frailty, but who did not make use of the care and repair services. So in the study that we did, we looked at data from the English Longitudinal Study of Aging, which is a large longitudinal panel study of people aged 50 and over. It started way back in 2002, and every 2 years or so, about 8,500 to 12,000 people are followed up until most recently in 2019. In this particular study, people were followed up for an average of about 11 years. In terms of the disability-related outcomes, we looked at, of course, we looked at falls, but we were also looking at more subjective measures like pain or reports of poor health. And we were also interested in whether people were able to participate in any social activities like paid work or voluntary work, education, caring, or looking after the home family. And we were very interested in seeing whether they were able to live in their own home or whether they had to move home in 2 years' time. In terms of the home modifications for factors, we looked at whether people's homes had widened doorways, ramps, automatic doors, accessible parkings or lift. And these we called external modifications. And similarly, we looked at whether people had handrails, bathroom or kitchen modifications or chairlift, and these we called internal modifications. And we were particularly interested to see whether people with mobility impairments, whether when people had long-term difficulties, either doing everyday activities like walking or getting up from a chair, climbing up a flight of stairs, whether people with these kinds of mobility impairments benefited more from either external or internal housing modifications. And here are some descriptive results. I apologize that it's quite a bit smaller than you might be expected. But again, all of the figures are available in the paper that I mentioned. So there are two kinds of contrasts here. The solid lines are people with a mobility impairment, with some kind of disability. And the dotted lines are people without any mobility impairments. And the other kind of contrast here are with people who are denoted by the blue line. So they're living in a home without any external modifications. And people denoted by the red line, that's people living in a home with external modifications. So if you look at the extreme left-hand side, which is just looking at the percentage of people who reported a fall in the last 2 years, we see, first of all, a big difference between people with mobility impairments, the solid lines, compared to people without mobility impairments, that's the dotted lines. So of course, it's unsurprising that if you have got mobility impairment, you're more likely to fall. But the other contrast here is between people with external modifications, so that's the red line, and people without external modifications, that's the solid blue line. And here we see initially in the sample, there is a difference between these two groups. So the people with external modifications are more likely to fall early on in study. But after about 6 or 8 years, this difference between the two groups living in houses with or without external modifications reduces. So they're almost the same. And we see virtually the same pattern for pain, for no social activities and moving home. For poor health, we also see a reduction in the gap. But we also see that that there's a huge amount of poor self-rated health amongst people with mobility impairments, even if they have external modifications. This is the descriptive results for external modifications. And on the next slide, if we can go to the next slide, we'll see a similar pattern for internal modifications, except that all the lines are almost parallel rather than coming together like we saw in the previous slide. Okay, you might be able to see a little bit of difference. This is the results of the statistical modeling here. And so we have two groups of people. Once again, people in the blue lines are people without any external modifications, and people in the red line are people living in homes with external modifications. And we see here that initially, for people with almost no impairments, on the extreme left-hand side of the graph, this is for falls, it looks like people with no impairments but living in homes with external modifications have a slightly higher risk of falling compared to people with the same level of no impairments but living in houses without any external modifications. But as impairments increase, for people living with, say, 8 kinds of mobility impairments, you see this protective effect of external modifications kicking in. And this is true for falls, this is true for poor health, this is true for pain. It's also true for no social activities and moving home, except that it's most visible here. The difference is most visible here for people with low levels of impairments. We'll see the results of the statistical modeling for internal housing modifications. It's very similar to the last one, except that some of the differences you can see are not statistically significant, but it's particularly significant, as you can see, for pain and for no social activity. So if you go on to my last slide, which is the concluding slide, it gives you some numbers. It shows that amongst people with some mobility impairments, we have robust evidence that external housing modifications reduced falls by around 3%, pain by 6%, poor self-rated health by 4%, no social activities by 6%, and moving home by 4%. So we found very consistent evidence that housing modifications can prevent a range of disability-related outcomes that ranges from falls prevention to health and well-being and social outcomes. And the main reason why I did this study is because I found that there was very little evidence out there in the research literature on the role of housing interventions in relation to disability and aging. And I just think we can't really ignore the role that housing interventions play, especially home adaptations. So so that's the end of my talk today. I just my very last slide, I just thank the funders of the research, which is the Economic and Social Research Council. Thank you, everyone.
Thank you, Tarani. What are your kind of thoughts on kind of next steps with the data you've got, and where else it might go, or where there's perhaps a lack of data that you would find useful?
Yeah, so as I said, the data are really very rich, and following on from our talk a few weeks ago, I've been looking at other data sets from Europe, from the US, that also have collected housing adaptations. And Paul, you mentioned there was a study from the US looking at the sort of effect of home modifications put in to support somebody's partner, and the long-term effect of those home modifications on preventing disability, on preventing falls in the person that originally, in the partner that originally didn't need those modifications. And I'm finding that's very similar results to the US study, using the English data, using the European data. So it's another way of taking account of these, the importance of home modifications, and also taking account of the fact that actually it's really hard to disentangle the protective effect of home modifications, because people usually have home modifications put in because they have some form of mobility impairment or disability. So it becomes really hard to say, oh, is it protective? Is it damaging? So having these large longitudinal studies are really useful to try to disentangle these differential effects out.
Yeah, and I think somebody put in the chat that kind of 4, 5, 6% seemed fairly low. I think if you look at 4, 5, 6% of every million people, then that's 40, 50, 60,000 people every year that are kind of being supported in their home, and that's kind of equivalent to the number of people who get a DFG every year. So I think kind of from that point of view, it does kind of show that there's a significant benefit when you kind of think that the government invests $500 million each year in DFG.
I have to admit, so the kind of methodology that I looked at was a more conservative methodology, where I just looked at differences within persons, so as people change. So that tends to underestimate the differences that you have between people. So usually when interventions are done, we're comparing two groups of people who have the home modification put in to people who don't have the home modification put in. And there you would normally find much larger differences. But here we're just observing changes that happen to a person within their lifetime. So it's internal changes, and it's well known that this kind of methodology that looks at within person change is really underestimates the differences. But it's a slightly more robust way of estimating these differences.
Yeah, and I suppose kind of one of the other issues is that kind of by the time somebody gets an adaptation, they usually, I suppose, in a decline of some sort. So it's kind of, I suppose it's unlikely that they're kind of particularly get significantly better after an adaptation. So that kind of weighs into the difficulty of measuring improvements, doesn't it?
Yes, it does. Yeah. And that's why I was looking particularly at this interaction between the level of mobility impairments, as well as whether or not people had a home adaptation put in or not.
Yes, absolutely. Well, thank you for joining us. It's not this afternoon for you, is it? But thank you for joining us.
Thank you for inviting me. It's about 10 p.m. Yes.
Okay. Thank you for staying up and joining us. And let's keep in touch. I'm really interested to kind of see what comes next.